So I was asked to speak about recovery, and we titled it From the Myocardium to the Patient Quality of Life, and I would like to give you a little perspective on clinical and research advances in this area. This is my disclosure statement. And I will start with a patient. So this is we tried, it was moving before the talk, sorry. 22-year-old female, non-ischemic cardiomyopathy, heart failure NYHA class 4, who's transferred to our center in stage D heart failure. Now she appears to be inotrope or is inotrope dependent. You would see on the echo images that she has a dilated left ventricle with severe LV systolic dysfunction. And oh, now it's moving. Okay, so, and pretty bad MR, as you can see there as well. Now, what I would like to do is to look at the future a little bit through the lens of the patient and the clinician looking at the patient as far what our different options are. Expected survival with medical therapy, continued medical therapy in this patient is very unfavorable. As you can see here, based on data from clinical trials, based on data from patients who are on inotropic therapy chronically for support of their stage D heart failure, we see that for a 22-year-old patient, this is a very unattractive option to continue. Now, heart transplantation, of course, has achieved fairly favorable results, and now median survival after heart transplant exceeds 13 years, which is quite favorable. Another good news is, and these are data from the International Society of Heart Transplant Registry that I have the privilege of heading, that actually numbers of heart transplants worldwide are increasing, especially in North America. So we're doing a good job at increasing the awareness of transplantation, organ donation, and using more donors. Now, despite the increase in numbers, still there's a quite big difference between the patients on the waiting list and a number of transplants happening every year. And so we just heard about the use of mechanical assist support for these patients, and this is, again, the blue curve shows expected survival of patients with bridge to transplant indication with durable continuous flow LVADs, and as you can see, at least in the short and intermediate term, with the option of bailout heart transplantation, the survival is favorable as well. However, I would like to share one more Kaplan-Meier curve with you, and I would suggest that this is not something we see every day in our literature. I would like to bring to your attention that the x-axis is in years, not in months, and that this is based on data from the National Health Census. So a 22-year-old patient like that I introduced you to at the beginning of the talk should have a 99.5% survival at 5 years and 99% survival at 10 years without their heart disease. So I think even with our advances, we still have some work to do to get back to the normal survival expectation in our patients. So the concept I would like to present is recovery, not in an acute cardiomyopathy or heart failure, but in a patient with chronic cardiomyopathy. And pose a question, is aiming for recovery a better option in some patients than what we have right now as standard of care, or could it be a better option? And the hypothesis here is that the profound mechanical unloading of the left ventricle that LVADs allow us to do today could decrease the load such that we not only achieve reverse remodeling, which we would expect, shrinking of the left ventricle, but also recovery, either full or partial, of the contractility and myocardial function. And I'll tell you, and this has become an interest of ours at the University of Utah, there have been investigations into bridge to recovery in the past in chronic cardiomyopathy, mostly with the first generation devices where the impetus was the devices didn't last too long, about a year and a half. So you either had to have a transplant or some other option. So maybe there was more focus on that with first generation devices. And the success rate for recovery in prospective bridge to recovery studies in these patients has ranged somewhere between 9% and up to 60%. However, when you look at the INTERMACS registry, the time to event at the bottom, you see that in our clinical care, it's less than 1% of patients where we actually explant the patients because we've diagnosed recovery and we feel comfortable to abort the transplant or abort destination therapy LVAD, take it out, and proceed with medical therapy for heart failure. So UCAR is a group of investigators at the University of Utah, and we've accepted as a known fact now that LVAD recovery with mechanical unloading can happen. However, there are many unknowns. What are the mechanisms for this recovery? What is the incidence? What is the likelihood of heart failure recurrence if you take the pump out? And how should we select patients, and are there adjuvant therapies you can add on to these patients so that you maximize the likelihood of sustained recovery? A few years back, we started by looking at our patients, bridge to transplant patients at the time of implant, at the time of explant, and just describing what are the structural and functional changes in these patients. We do see reduction of myocardial hypertrophy in these patients. We do see normalization of ultrastructure, as you see at the bottom slide, under electron microscopy. Also, what has been a concern in the past is, does chronic LVAD unloading lead to atrophy of the myocardium that we need to reverse before we could explant the pump? And that's why clenbuterol, you might remember, has been used in some of the bridge to recovery trials. In our investigations, we have not seen evidence of reversal of hypertrophy to the event that the myocardium would proceed to atrophy. So we don't think necessarily action to prevent that needs to be taken. We see that microvessel density improves after LVAD unloading. And most importantly, and now these are not patients that have been explanted, but these are patients with a prospective protocol where we do turn-down studies with the LVAD echocardiograms regularly after LVAD implant. There's a sizable number of patients where we do see a reduction of left ventricular end-diastolic diameter, and we see improvement of myocardial function to mild or normalization of LV function. That's the one on the slide, where EF is 40% when you turn down the pump or more, and to the moderate range from, of course, all these patients had severe LV dysfunction. I'm sure you would be interested to see, well, which patients those are as far as etiology, and we've seen when we looked at responders and non-responders that this phenomenon is more likely in non-ischemic cardiomyopathy, where we see about 20% of patients probably achieve at least 40% EF after LVAD unloading, and it's a little bit it's less likely, about 5% with patients with ischemic cardiomyopathy. Now, we've now moved to try to find out mechanisms of this recovery to understand it more. The translational lab that's led by Dr. Drakos, my partner, has focused on metabolism and determining which mechanisms could lead to recovery. Now, I know there's many basic scientists in this room, so it takes some guts for me to put up a Krebs cycle here, right? But we do see actually that there's glycolysis upregulation after LVAD unloading, and there might be mismatch in pyruvate mitochondrial oxidation, such that this increased availability of energy is not picked up by the myocardium in all patients, and we've seen in those who are less likely to respond and less likely to improve their myocardial function, there's decreased number of mitochondria and inefficiency in metabolism of mitochondria, and we have some ideas how to reload the myocardium and maybe improve its function before the eventual explant would take place. Now let me take it back to the patients and to the INTERMACS registry, where we said only about 1% of patients get explanted. And we've recently looked at the INTERMACS registry as far as patients who do get explanted. There's actually also a way in INTERMACS to see if the indication for the LVAD implant, again, this is durable LVAD implants, so chronic heart failure, was bridged to recovery. And in those patients, the percentages of patients that get explanted are actually quite higher. And we've seen some predictors of higher likelihood of the myocardium recovering and the physicians actually taking the pumps out, which includes some, probably not surprisingly, younger age, longer duration of heart failure, better renal function, and smaller size of the left ventricle. And with these predictors, actually you can see, we set up a score where you can see fairly good discrimination as far as the likelihood where the recovery might happen. And we looked at it in the INTERMACS registry and validated in our own sample at the University of Utah, and we've seen similar stratification of the likelihood of recovery. And of course, with this as an indication that this is a phenomenon that could happen, and that we are doing it at different centers, however, probably don't have standardized protocols. I think the next step that will be very important is clinical trials that will test that in a controlled way. And we've just completed enrollment in the multi-center restage heart failure trial, where it's a pilot study, 40 patients with non-ischemic cardiomyopathy, maximal medical therapy on the LVAD, and clear criteria for explantation of the LVAD, as you can see here. Reverse remodeling as far as diastolic diameter, LVF more than 45%. We do right heart catheterization with pump turn down and max cardiometabolic stress test. If all those check out, we actually proceed and expand the pump. We should have some results fairly soon, but I can tell you that a significant proportion of these, I accept fairly selected patients, but patients with chronic heart failure with remodeled hearts underwent LVAD explantation in this multi-center study. Now, I titled the talk From Myocardium to Quality of Life, and I won't have too much time to talk about quality of life. However, I've noticed some questions here in the morning that were asking about patient experience with disease, patient-reported outcomes, and how can we integrate it into clinical care and bring it closer to the patient and focus on things that are important to the patient. How are they feeling? And so in this context, what we've started doing in these patients, especially in context in recovery, but we expanded it to all heart failure population, is we started collecting patient-reported outcomes at the time of every clinic visit. And they are not on paper and reviewed later, but they're real time, and we get the results within a couple minutes of the patient completing the PRO so that we can look at the results and share the results with the patients. It has also helped us in patients, these are just two examples, in patients who undergo LVAD explant to monitor their quality of life in a little bit more objective way than just assessing the NYHA, which is a physician-reported description of how patient is doing. And you can see here on the left, that's one of our patients who's done really well after LVAD explant, and their Kansas City cardiomyopathy questionnaire scores are in the top 10%. And on the right, you see a patient who actually had a recovery of heart failure after explant, and actually the patient-reported outcomes have triggered or alerted to something happening sooner than actually objective data as far as echocardiography or what patient was reporting. So let me now go back and go back to the expected survival. What would we expect of recovery with LVAD unloading to do for the patient long term? So the idea is, and here you can see the normal survival with transplantation, and the middle curve is in blue, the bridge to transplant. Here it would be bridge to recovery strategy. If we have full recovery of myocardial function, we would expect that hopefully the survival curve gets back as far as long-term outcome where a healthy population survival should be. And this would be, this is a paper that just came out in JACC from a European group of investigators who did some of the original work, and they looked at physical function in patients with long-term recovery, and it is in the normal range. So that would support what I'm proposing, that survival should be in the normal range as well. Now, how about partial recovery? Maybe we achieve ejection fraction 40–45%. Is that good enough? Well, I would propose that most of our patients in our heart failure clinic treated medically with stage C heart failure do have mild to moderate reduction in ejection fraction. They have higher risk of mortality, and maybe even partial recovery we could consider as a success, because we should get at least as good survival as in heart transplantation. And of course, we need to be ready in case there's recurrence of heart failure to intervene so that we prevent deterioration of this patient that could happen in a faster way than new onset heart failure. Now, what is the potential impact, right? So I showed you 1% in the INTERMACS registry. I showed you 10–60% in carefully selected patients. Well, I would propose that with the increasing number of LVADs being placed for bridge to transplant, especially for destination therapy, even if that percentage of patients actually explanted is not really high, but it's in the 10–20% range, on the patient level, this could make an amazing difference in the future of these patients, and as well as redirect some of the precious resources like transplantation to patients who do not achieve recovery. So let me finish by going back to our patient. This is her 9 months after LVAD unloading with her LVAD and with medical therapy. I'm out of time now, but I would invite those of you who are interested to see what happened to this patient to the breakout session tomorrow, where we can continue to discuss this topic. And I would propose to all of you and all of us that our goal in advanced heart failure should be this survival curve, and maybe bridge to recovery strategy will get us closer to our goal. Thank you very much. Appreciate your attention.